Okay, welcome to another live Q&A session with Toronto's Associate Medical Officer of Health, Dr. Vinita Dubey joins us again today. Thank you for joining us, Doctor.
Thanks for having me. Good afternoon.
Good afternoon. So my name is Dilshad Burman. I am a writer and reporter with citynews.ca and 680news.com, and I will be moderating this chat today. We have been getting questions all week from all of our viewers and listeners, so we're going to go through them one by one. If you haven't had a chance to submit your questions, you can do so under this live broadcast, and we're going to try and get to as many of them as we can in this quick half hour that we have with the doctor every week. So let's get started.
Let's go.
Awesome. So we'll start with some very large, broad questions, more like existential questions people are asking nowadays. Dee and Ashley are both asking, when this pandemic is over, will things go back to normal like we knew before?
So yeah, I think we can hope for that one day. Yes, whether that's going to be a year, 2 years, many years, it's hard to know. But we've certainly seen that we have been able to produce vaccines for other diseases. If we can produce a vaccine for this illness, then we can get to some more sort of normalcy. And the reason why I talk about a vaccine is because we've seen public health measures have to be very strict and very restrictive in order for us to carry on with our day and not end up with too many people in the hospital where we actually don't have enough ventilators for people who are very sick. But we've also seen that if we let things kind of run their course, people continue to get sick and you can get reinfected. And so that's not a good strategy either. And so waiting for a vaccine, I'm confident that we're going to get one that's going to work well enough. And then we can, once we have some sort of a herd immunity where, you know, a proportion of our population are protected, well, then the threat of too many people getting infected at once will go away.
Right, absolutely. And I think people keep comparing this to the 1918 flu that happened. And I mean, ultimately, we did get back to normal after that. So hopefully, fingers crossed, this will be the same.
Yeah, it's different because this is a coronavirus, not a flu virus, yes. But it is absolutely, pandemics don't last for the rest of our lifetime. And so that is the hope, yes.
Okay. And then Chris asks, what have we done in the last 6 months to prevent what we saw earlier in the year from happening again?
So it's all of those public health measures, and it was actually the restrictions and then slowly opening the restrictions. You saw we had different phases or stages of opening, and now Toronto has gone back into a modified stage 2. And so essentially what we're trying to do with what we've learned is to prevent people from having that close contact in situations where the virus is likely to spread. And unfortunately, because we've had so much activity in our city, it means that we have to dial back some of that because there's too many cases going around that if we get together in a gym, the virus is likely to spread. And so I think that's what we've learned on how to go forward. And sometimes we have to take steps back in order to keep moving forward.
Right, absolutely. And then Ab just asks, you mentioned that we've had to roll back a little bit. He asks if there's going to be another lockdown all over again.
We certainly do not want another lockdown. I can say that with total confidence. We recognize that lockdowns have a lot of negative effects on a lot of people. It's not just about COVID. It's about mental health. It's about the economy. It's about people's livelihood and jobs as well. And so that's why you can see we've kind of dialed back. We've put in a few more restrictions. But are certainly hoping that we don't have a lockdown. Now, if we don't do anything now, the modeling projections show that we could have thousands and thousands and thousands of cases by early spring. And so if that's the case, there could be a lockdown, but we're certainly trying not to do that.
Absolutely. I think it also, like you said, it goes as per the modeling, and if that actually comes true, right? It's wait and see, essentially.
Well, also the time to act is now. And so putting in a few smaller restrictions now is going to help prevent us from getting a lockdown later on. And so while it's tough to understand why are we doing this, for those like for gyms and for restaurants to have to go through more restrictions is extremely, extremely difficult. But the hope is that if we do it now, it won't last for as long, and we can carry on.
Right, absolutely. And then you mentioned vaccines earlier. So Janet asks, do we have any idea when a vaccine is coming? Are we any closer?
We're certainly closer. Yes, every day we get closer. There are what we call phase 3 clinical trials, which are actually trialing the vaccine on humans. That's kind of one of the last steps in order for a vaccine to apply to be licensed. And so once those trials are finished, vaccine manufacturers can apply for a licensure through Health Canada. And so we are closer for sure, but not there yet.
Okay. Okay. And like you said, I mean, vaccines have to normally take about, we keep hearing 18 months to 2 years, and you definitely want it to be safe. You don't want to put something out there, you know, in a rush, especially when it comes to so many people's health.
That's right. And so doing those studies to prove, first of all, the vaccine works, and secondly, that it's safe. That they're really important. And so we do have to wait for that. Exactly. We can't just say, okay, we have a prototype of a vaccine, let's just give it to everyone. That would not be ethical.
Yeah, absolutely. And then Carl asks, what was the percentage of positive cases that were asymptomatic? And if the percentage was high, or we don't even know what the percentage was, why have we stopped testing them without pleading for more support from the government?
So it depends on which groups you look at in terms of how many were asymptomatic. So I can give you some examples. Among children, we know that children tend to have milder symptoms. Some may be asymptomatic. And we know that 30% of our current cases in children were asymptomatic. Now, asymptomatic testing is still going on, actually. It's just that it's defined asymptomatic testing. And what I mean by that is, if you were a contact of a case, if someone you know who you were close with got COVID, we will recommend that you get tested even if you don't have symptoms. And so that would be someone who's asymptomatic who would be recommended to go for testing. And if they become positive, that would be counted as an asymptomatic case. So what we've dialed back on is having anyone who decides they want to get tested. And we saw that people were going for testing even inappropriately. They were going for testing and thinking, okay, I'm negative. Now I can go to this party, or I can go away to the cottage. And that certainly is not a good use of testing resources.
Right, absolutely. So like you said, asymptomatic testing is still happening, but it's under certain cases and if there is risk that they might have been exposed.
Exactly. And so actually what you define that, if there's risk that they might have been exposed, or there's a more likelihood that they have COVID, that's called a pretest probability. That's our science term for that. And so it's trying to really test those who are asymptomatic, who are more likely to be positive. And then you're gonna pick up more of them. Right.
Okay. Tom has a question about contact tracing. He says, when contact tracers cannot even contact 50% of the new positively ID'd COVID cases themselves within 24 hours, the process is obviously missing something critical. Did the proper information not get collected at the time? How many contact details are collected, and what are we doing now that we've identified these gaps? What are we doing to fix it?
Well, I have great news for you, Tom. Through the weekend, we've actually been able to reach more than 90% of newly notified cases within 24 hours. And so that's really great news. And as we get less and less cases, as the case counts go down, we'll be able to reach more of them, and then can consider when we start doing that full contact tracing. So, the number of, when we were only able to contact 50%, part of that was because we were also doing the full contact investigation, not just the case investigation. Sometimes we don't have all of the identifying information. Sometimes that can be a problem, but we've actually worked with our labs, with assessment centers, to make sure that some of those kind of logistical barriers are not the main drivers on this.
Okay, so we're getting past that 50% mark. We're definitely contacting more people now.
We're contacting the cases, yes. So over 90% within 24 hours this past weekend, and so that's really, really great news.
Okay. And then Bunny asks, about half of the new cases reported every day have no known epilink, which means that you don't know where the person caught it from. What can be done to improve this percentage?
So we can't actually look at our most current statistics now because we're not doing that full investigation to find out, well, where did they get it from? Is there a link? And we stopped that this past week because of the higher case counts. But if you look back to our previous data, about 25% of people have what we call community transmission. And that number, you want to keep an eye on that number. It's about 1 in 4 who can't definitively pinpoint where they got the virus from. Things like having the app are going to be helpful because it may notify you that you were exposed without not realizing that you were. But I agree with you that that's a number that we want to keep a close eye on, because if we're finding more and more people are getting infected and they don't know about it, it means they're having close contact with people in different situations. And that's something that we know contributes to the spread of the virus.
Okay, so when it comes to that, then how do we we have to keep an eye on it, but how do we mitigate that? Is there any sort of way that we can figure it out? Is there anything more we can do?
Well, if we urge people not to have close contact, so reduce the gathering limits, like these restrictions that have come in place, are part of it are to address that, to exactly address that, you know, so that the indoor dining, if there was a chance that you could have been exposed to someone in that setting, you wouldn't know about it. That would contribute to that non-epilink case. So now we've put a halt on indoor dining, for example.
Okay. Jason asks, why are hospital capacity numbers not front and center along with infection and death rates in the daily numbers that we get?
Actually, they are available. So if you go on our website and you go to the monitoring dashboard, if you go to the statistics page, there's a tab up there that says monitoring dashboard. And one of our key indicators are related to hospital capacity. So you can certainly find it there.
Okay, wonderful. On the Toronto Public Health page.
That's right. Yeah, toronto.ca/COVID.
Okay. Kate asks, can you test negative multiple times and still have COVID?
Anything is possible, actually. I think part of it depends on what's the test that you're using. Again, how likely is it that you have COVID? You know, when did your symptoms start? Do you have symptoms? Were you exposed to anyone? If you have very classic symptoms, you lived in a household with someone who had COVID and you continue to test negative, well, then we would wonder, is that really a true negative? Sometimes the viral shedding, that's kind of our medical term for saying, you know, we rely on that to be able to detect the virus to get a positive test. And that can contribute to, you know, when you may or may not test positive. But that's why we do have some other tests. I mean, we do see in children who get that very severe illness, the multi-system inflammatory condition, when you test them for COVID, they can often be negative. Maybe they had COVID a month ago. And so that's why in some situations we rely on something like antibody testing, for example.
Okay. And then this one we've had earlier during the pandemic, but I think bears repeating now. Terry asks, can you get COVID more than one time?
You probably can, yes. I mean, there have been case reports of people who have had the virus and then it was sequenced, so they know exactly kind of the fingerprint, you know, the DNA of that virus, and then they got symptoms again, were tested again, and the fingerprint of their new infection was different, which shows that they were two different slight variations on the strain and showed that you could have been reinfected. Now, how often that occurs, it's very difficult to tell, but there have been reports of it. Okay.
So M has some concerns about her roommate. She says, my roommate has a sore throat and refuses to go for a test. She's now improving after day 4. What do you suggest I should do?
Well, anyone who has symptoms, we recommend that they self-isolate like that. And that's the term that we say for anyone, whether you're in school, whether you work, whether you're at home. And you want to self-isolate from people who you live with because you could be contagious. Even if it's not COVID, you could be contagious with strep throat or whatever else it is. And so the recommendation is that that person who's sick, stay in their room, limit contact with others. So if it's your roommate who's sick, what you want to do is ask your roommate to stay in their room. Maybe you stay in your room, you wash your hands, wear a mask when you're around them, all of those kinds of things.
Okay. And then another roommate question. Scared Rumi asks, I am a female with mild asthma and diabetes, and I'm not in the greatest shape. My roommate went to a big family Thanksgiving dinner this weekend, despite the public health warnings and my apprehension. Is there anything I can do to protect myself now?
Yes, so you can stay away from your other roommate for 14 days. So I think, so actually going back to the first roommate, the roommate that has symptoms, they can be contagious for 10 days if it's COVID. And so if you want a number, it's stay away for 10 days. In this situation, this roommate had potentially an exposure. They were with their family, and it can take 14 days from when you were exposed to when you develop symptoms or could be contagious. And so you want to keep your distance, so to speak, for 14 days after the Thanksgiving dinner that your roommate went to.
Okay. And then we have one coming in live right now. Since you have to make an appointment for a COVID test, are the daily numbers reflective of the current testing process? Meaning, could they be higher and we just don't know yet?
From what I understand, the testing numbers, the number of people they've been able to test every day, continue to be high. So continue to be 30,000 or more. I don't have the specifics for every day, but the number who are tested haven't declined rapidly. So I think that's important to note, that there are still thousands and thousands of people who are getting tested. And it's not that we're necessarily missing a whole segment. Unlike in the spring, like we knew in March, we weren't testing everyone. And so, you know, as long as you meet the criteria, you should be able to get a test.
Okay. And then let's see. We've got Kathy. Kathy says, I had a COVID test last week and have not received any results yet. I'm feeling much better than I did, just feeling cold symptoms and maybe a headache. I'm under the impression that I should not return to work till I get my results, whether they be negative or positive. Can you clarify this?
So that's correct. So if you had symptoms, and you got tested, good for you for going to get tested. Now you have to wait for your results, and I'm sorry that the results have taken a while. When you get your results, if it's negative, as long as your symptoms have been improving for 24 hours, you can go back to work. If, however, you didn't get tested or your results are taking, for some reason, a long time, after 10 days from when your symptoms started, as long as you don't have a fever and your symptoms are getting better, you can go back to work.
Okay, okay. So, so it doesn't necessarily have to be that you get your test result back.
Some people don't go for testing,
right?
And so that's why we give the 10-day option as well. But if you went and got tested, you should get your results back, I hope, within 10 days.
Okay. And then Josh asks, in the NHL bubble, they were using nasal swabs, just Q-tips that were spun around the nostril, not jabbed into the back of your brain, he says. Why don't we have those, and why don't we get instant results like those players did?
Okay, so two things about the NHL bubble. Yes, they did what we call anterior nasal swabs, which were not the deep nasal swabs. They got tested every day. So that's, I think, an important point to say, that we still think that the deep nasal swab is the best test. So if you're only going to be tested once, that is your preferred option. Whereas, you know, if you're getting tested every day, the anterior nasal swab is something that you can consider. They didn't get instant results, actually. Those tests that they did had to go to the lab to be processed, and they got their results that way. The labs that they went to were mostly in Ontario. Some of them got shipped out. They were private. They were not through public funds, and it was in the summer when, you know, that it wasn't quite a high demand, and so the results would come back within a day or so, and that's how they would get the results.
Right. So not quite instant yet.
They weren't the instant tests, no, and they weren't available at that time. The other thing to note about instant tests is sometimes they're not quite as accurate, and so that test that's done, that's sent to the lab, is still the most accurate test.
Right, right. So Sean asks then, we know that viruses like to mutate. How many variants of COVID do you feel have been active or are actively circulating right now? And do you feel they pose any risk of airborne transmission?
So it's a good question. We know that influenza virus mutates sometimes within a season. Sometimes you have what we call cross protection, sometimes you don't. And we're seeing that there are different variants on that fingerprint of the virus through different people's infections. I'm not right now aware of multiple strains of the virus, like distinct enough that they infect differently or that your immune response is different enough. So it's extremely possible that it's there. And so again, we'll have to keep track of the microbiology literature on this to see what's going on.
And then when it comes to the risk of airborne transmission, we've spoken about this several times. There's been lots of people reading things online. Different studies are being published about the fact that it might be airborne now.
Right. So let's describe, so the airborne transmission, again, I still think is important to note that it's still different from something like measles or chickenpox. But it's this idea that the droplet, if it's a tiny droplet particle, aerosolizes. And I think we've talked about, we knew that there were aerosols generated. And classically, we thought it was for medical procedures. We call them aerosol generating procedures. So if you're hospitalized and they intubate you or they suction the back of your throat because you're very sick, that can produce aerosols from the droplets, very small particles, and that can be airborne. And so I think it's the same idea that may be contributing to airborne transmission here related to this virus, where if you're in a very poorly ventilated room, the air is not circulated, these small droplets, maybe it's from exercise, maybe it's from singing, maybe it's from talking or shouting loudly, they get suspended in the air and they can stay in the air for longer than a large droplet that falls to gravity. And so that's how this aerosolization or airborne type transmission occurs. How long does it stay in the air for? Does it stay in the air for 2 hours like measles? I don't think so right now, but again, I'm learning just as much as you are as we go along this.
Okay. So there are in certain circumstances, I would say then, the chance of airborne transmission, but we don't know enough about how long it's suspended. Like if somebody leaves the area and then you walk into it, there's no clear data on that.
That's right. And what if you're wearing a mask? Does that, will that prevent airborne transmission? What about if you're just sitting, maybe talking with a mask on compared to exercising without wearing a mask? All of those, and then the ventilation. We've talked about ventilation, right? Outdoors versus indoors, and that's why there is some sort of the air matters, and that's why outdoor is safer. So it is going that recommendation is not new. It's going along with what we always recommended, that you need good ventilation to combat this virus.
Right. And then let's see, we've got a few school questions. The first one is it safe to send a special needs kid to school right now?
Yes. Everyone has to be able to make their own choices. And so, I don't want to say yes blanketly, but I think just as a parent, you have to decide on the health risks for your special needs child. But schools have in place measures to protect all of the children, including those who may require one-on-one care. And so I think if you have concerns, then you should talk to your school, your principal about them. But ultimately, you're going to have to make the decision based on what you know about your child.
Absolutely. And then a related question then with schools. Sydney asks, if one person in a classroom gets COVID, does the whole classroom have to quarantine for 7 or 10 days?
If one person in the class gets COVID, yes, the recommendation is that the whole class be dismissed. We're working with principals so that they can start to dismiss them as soon as they find out the result while public health is doing their investigation. And then how long they're dismissed for, it's up to 14 days, but it will depend on when the person who got COVID and was contagious when they were last in the classroom.
Okay. And then Minnie asks, if the parent is sick and the child is asymptomatic, can the child go to school, and can the parent pick up and drop off that child?
If the parent is sick, the parent should not be leaving the home. the parent needs to stay home and self-isolate, they could leave the home wearing a mask to get tested, or if they need medical care, they should not be leaving the house to pick up and drop off the child. If they're unable to drop the child off otherwise, then they should keep the child home. But now, can the child go to school? As long as the parent has not been identified as a close contact of someone who had COVID, that child, as long as the child has no symptoms and can be dropped off by someone who has no symptoms, can still attend school.
Even if the parent is sick themselves?
If the parent gets tested, until the parent's results come back, the child can attend school, as long as the child has not even one symptom, and as long as the parent has no close contact with someone who had COVID.
Okay. Those are very specific instructions, though. So it's not a blanket thing. If you're sick, you can let your child go to school. Yeah.
That's right.
Okay. And then this one, we've talked about this a couple of times, but again, because we're talking about restaurants and takeout food, Patricia asks, my brother doesn't think it's safe to have takeout food, but she says that stomach acid destroys COVID, correct? So is it just the packaging and handling that you have to worry about, or also the actual food?
Okay, so there's a couple things. For the actual food, because we have food regulations in Ontario, because restaurants are required to follow it, public health inspects those restaurants, you can be sure that the food has been handled in a way that is safe, and so COVID is not likely to be in the food. If there was a little bit of the virus that causes COVID in the food, by eating it, as you said, your acid would kill the virus. It's not likely to spread. You're not likely to get COVID that way. But you're right. What is important is that when you get the takeout, that you wash your hands before you deal with the food, after the food, any packaging that you remove it as well. Okay.
And then you were talking about ventilation, and so Concerned Engineer asks, why are we ignoring the fact that COVID-19 can spread indoors by the building's heating system?
We haven't seen that the HVAC, the heating ventilation systems, by those currents, that the droplets that are in the air conditioning or heating system will actually spread it from one room to another. We haven't seen that. What we do recommend, though, with those systems is that they have air exchanges, and multiple air exchanges, as many as the system can handle, are recommended, so that airflow is continuing to go through, so that way, if there are droplets in the air, they will get diluted and they won't be spread from room to room.
Okay. And then this is an interesting one. We haven't had this before. Ali asks, at an eye clinic, they use a machine to test the visual field. This machine cannot be fully sterilized, and the head actually goes partially into that machine. Is it still safe to use? Why is it still being used?
I would ask the eye clinic what their protocol is for cleaning the inside of the machine, and to make sure that they've cleaned and disinfected it. There are many different kinds of machines, and so if it can't be safely cleaned or disinfected, it shouldn't be used. And I think the other thing that's important is, before anyone were to use any sort of medical equipment, to make sure that no one has symptoms, that kind of thing. But I would ask specifically at your eye clinic, what is their protocol for cleaning that machine?
Right. And we have just 1 minute, so we're going to squeeze this in really quick. And this is one of our most popular questions. How can someone get an antibody test to see if they were previously infected with COVID-19?
So you can't get one that's publicly funded unless you have very specific criteria. There are some labs, as I understand, that you could pay for to go and get one done. And so you could look those up from those labs. Again, before you go for the test, I think it would be important to ask what is there a specific episode when you had symptoms and people who had COVID, and you're wondering, well, maybe that was COVID and you want to know. But you also have to ask yourself, when you get the results, what are you going to do with the results? Is it kind of to meet your own curiosity, which I completely understand, versus to say you don't want to take those results and say, okay, now I'm immune, I can do whatever I want, because there's no evidence for that.
Right, absolutely. And on that note, it is 1 o'clock. That half hour always goes by so fast. Yeah. Thank you so much, Doctor, for joining us. And thank you to everybody that submitted your questions. And we will chat with you next week again.
Okay, thanks. Bye-bye.
Bye-bye.